Hello, and thank you so much for joining me today. My name is Dr. Nina Shah from the University of California, San Francisco, in San Francisco, California, where I specialize in multiple myeloma. I'm delighted to talk to you today about relapsed and refractory multiple myeloma, since we've had so many changes over the past several years. So what is relapsed and refractory multiple myeloma, and what does it mean to have a line of therapy? These terms can be confusing for a lot of patients, and it's important that we make sure that we're clear about what this means if you should hear it in a clinic visit. For relapse, we think about that as a recurrence, so that can be reappearance of disease after a previous response to therapy. Sometimes your doctor might say there's a new finding on a PET scan, for example, or maybe you had an M protein that was 0 and now has reappeared. Refractory means that there's progression despite ongoing therapy. So in this case, it would be as if you're getting therapy and yet your numbers aren't going down, and worse than that, that they may be going up, and that would be refractory. Progression is a change in the M protein or the light chain values, or even sometimes the urine values, that can signal that the disease is growing. We have certain criteria to decide that something is officially progressing, but a rise in this number usually is one of the signs that there has been progression. And then there's line of therapy, quite possibly the most confusing thing, not even for patients, but for doctors. And this means a change in treatment due to either progression of disease or unmanageable side effects. And it's really important to know that thinking about what you might have done as you got your initial therapy, like induction therapy plus transplant, plus maybe consolidation, and then maintenance therapy, that's all just one line. So some people may have had one line of therapy for 5 years. And so it seems like a long time, but it's just one line because that's all planned. So when we think about options for relapsed and refractory to disease, we know that these options continue to increase, which is a good thing because we can offer patients more options for treatment and more decisions that can be made with the patient deciding about what's good for him or her, and also maybe for lifestyle, quality of life, and the disease itself. There are a host of different types of therapies in different categories. And you can see in this table that there are a lot of different mechanisms of actions. So we have IMiDs, and those you may have seen as immunomodulatory drugs. And the oldest one is thalidomide, but now we know about lenalidomide, also known as Revlimid, and pomalidomide, known as Pomalyst. Proteasome inhibitors are a different kind of myeloma drug. They work by irritating the garbage disposal of the myeloma cells. And we have bortezomib or Velcade, carfilzomib, Kyprolis, and an oral proteasome inhibitor, Ninlara, also known as ixazomib. There's traditional chemotherapies like adriamycin and doxorubicin, and alkylating traditional chemotherapies, Cytoxan, bendamustine, melphalan, of course, steroids, the drugs everyone loves to hate, right? Dexamethasone, prednisone. And then there are novel mechanisms of action that research has led to recently. For example, Expovio, also known as selinexor, which is a drug that impairs the ability of the cell to export proteins from the nucleus and allows for proteins to be retained so that the cells can continue to be suppressed. And this is actually particularly important in myeloma. We have another drug called venetoclax, which tends to work on patients with translocation 11 and 14, and this is a BCL2 inhibitor. We had some other drugs that have been recently taken off the market. You may have heard of panobinoside or melflufen, no longer being used for myeloma. And then really exciting monoclonal antibodies, elotuzumab, also known as Implicity, which targets SLAMF7, and Darzalex and Sarclisa, also known as daratumumab and isatuximab. These both target CD38 and are becoming very important in myeloma care. And finally, Blenrep or belantamab mafodotin, which is a BCMA antibody which is conjugated to a toxin or an antibody drug conjugate to specifically deploy this weapon of a drug called MMAF to kill myeloma cells. Now, we most recently have cellular therapy, which are engineered T cells that are targeting a specific protein, in this case, something called BCMA, or B cell maturation antigen. And we have two cell therapy products that have been recently approved. One is Ida-cel, or the trade name is Abecma, and most recently, Cilta-cel, also known as Carvykti. So all of these things are so important, and I always say this, that it's so important that many patients have participated in clinical trials to make this table possible. So we're always thankful to them. And the truth is, numbers of therapies are continuing to increase, which we hopefully means more time and more quality time for our patients. So how do we choose therapy for relapsed and refractory myeloma? First, we have to know what about the patient's myeloma. So what about the prior therapy has been used? What prior therapies worked? How well did they work? did the myeloma progress on this therapy? This is something we'd say if the patient had progressive disease or refractory disease, and what is it about the myeloma that characterizes it? Does the patient have high-risk cytogenetics or FISH, gene expression profile? Now, putting aside the actual disease, we have to think about the patient, who of course is not just a patient, but a person. So what about that person? Age, other medical problems, maybe they have diabetes, history of blood clots, maybe they have neuropathy from previous therapy, and also there's personal preferences and values. Some people don't want to go to the oncologist's office. Some people really don't mind going to the oncologist's office. Some people don't have access to get infusion. Some people prefer one-time therapy, or some people prefer continuous oral therapy. These are all very important things to consider. Now, when looking in treatment selection and what you might consider, as we talked about, there's disease-related factors. For example, how long did the patient respond previously to their initial therapy? Was it a very long remission, and therefore we can have a whole new set of drugs to treat it? What were the FISH and cytogenetic profiles? Is there high-risk disease likely to be rapidly progressing? And then what happened for prior treatments? For example, how long were they exposed to a certain drug? How did they tolerate it? How did it go having IV or oral or subcutaneous? And did they have a previous transplant? And again, patient-related factors. Do we have toxicities that are still lingering from previous therapies? Are there other conditions that are important for the patient that might impact how they would tolerate a therapy, general health, personal lifestyle, and preferences? So there's sort of a broad way to approach patients with relapsed and refractory multiple myeloma, but certainly one size does not fit all. You can see there's treatment approaches that sort of go based on what happens in the past. So in the first relapse, you may consider, again, using a PI, maybe a different one, an IMiD, and possibly an antibody-based therapy. After the first relapse, you basically have to think about what haven't you used before. So if there are any options for first relapse that were not tried, you would then consider using those options in the second relapse. So if they were refractory to Velcade and Revlimid, you might try something else with daratumumab, an antibody-based therapy. If they were refractory to IMiD, but not quite refractory to Velcade, you might consider using Velcade again, maybe in combination with selinexor. Now, patients that are triple-class refractory are those that are refractory or have progressive disease to the three main categories of drugs, which include the IMiDs like lenalidomide or Revlimid, the proteasome inhibitors like bortezomib or carfilzomib, also known as Kyprolis or Velcade, and then an anti-CD38 antibody, which we have daratumumab, also known as Darzalex, or isatuximab, also known as Sarclisa. Now, when this happens, we know that patients really need help. Now, there are some approved therapies that you can get, for example, selinexor, belantamab mafodotin, T-cell therapy like ide-cel or cilta-cel. And then there are clinical trials. If you happen to be connected with someplace that does clinical trials, that might offer you something like a bispecific T-cell antibody, a novel CAR T-cell, or maybe a cell mod that's new. So what about options for patients who have received 1 to 3 prior line of therapy? So we have actually a good number of drugs available for patients, and we have proteasome inhibitors as some of the backbones here. We have Velcade or bortezomib, which can be given IV, but most commonly is given subcutaneously. We have carfilzomib or Kyprolis, which is given IV. It used to be given twice a week for 3 out of 4 weeks. Now we've kind of moved to once weekly for 3 out of 4 weeks after having demonstrated that that's actually pretty safe. Now you can use that as a triplet with Revlimid or Darzalex plus dexamethasone. You can also use this with isatuximab as well, also known as Sarclisa. And then we have Ninlera, which is, as I mentioned, an oral proteasome inhibitor. That's a once weekly pill, 3 weeks on, 1 week off. Again, can be used in combination with Revlimid and dexamethasone. Most commonly, you'll see that in the 1 to 3 prior lines, you are using triple combination chemotherapy because we know that 3 drugs usually does a better job than 2. Now, we think about proteasome inhibitors with previously received 1 to 3 prior lines of therapy. For those patients, the studies that looked at this, for example, were Kyprolis, and we have the Endeavor study, which looked at Kyprolis and dexamethasone versus Velcade and dexamethasone. So this is really the new versus the old, and this did show a benefit for patients to get Kyprolis over Velcade, who had previously received Velcade. And then the Aspire trial, which used a 3-drug versus 2-drug regimen, KRD versus RD, or Kyprolis Rev-Dex versus Revlimid dexamethasone, and that did actually improve not only progression-free survival, but overall survival in comparison to RD. So the 3 drugs of KRD was better than RD, and that had really a lot to do with that, and the Endeavor study, a lot to do with our thinking that Kyprolis is a very effective drug and is one of our go-tos in the relapse setting for patients with 1 to 3 prior lines of therapy. Now, again, we talked about Ninlaro, which is an oral proteasome inhibitor, and the Tourmaline-1 trial looked at Ninlaro RD or IRD versus RD and did show an improvement in progression-free survival. So this is also a option that you might consider after the first line of therapy. Now, each of these drugs is different. They have different developments and they have different side effects. Probably the most important thing to know about Velcade, and many of you probably already know this, is that it can cause peripheral neuropathy, which can manifest as numbness, tingling, burning, this feeling of nerve damage, and that can be even worse at night. It can cause low platelets and some GI issues, but I would say that the most important side effect of Velcade is this peripheral neuropathy. It does cause immunosuppression, so you have to take that acyclovir or valacyclovir to prevent shingles. Kyprolis, on the other hand, which is IV, can cause a lot of fatigue and sometimes lower blood counts and nausea. It has the other side effect of having cardiovascular effects potentially and can cause high blood pressure, shortness of breath, and rarely cardiac toxicity. Again, it's something, know before you go, something that's manageable. If you've had no heart problems, it's probably okay. You can maybe get an echo before you start this therapy to consider and think about how your heart is before starting this, knowing that you don't have any underlying cardiac issues and feeling a little better about starting it. You can also make sure to limit the IV fluids that goes in with each of these. Then we have Ninlaro, the oral proteasome inhibitor. Now, it is oral, so it can cause some GI side effects like diarrhea and constipation. It can also cause some issues with the platelets. Nausea, of course, is a GI side effect and can cause some edema or swelling. Now, for managing these, we have to think about how we can make things better. So the peripheral neuropathy for Velcade is seen less often in the subcutaneous versus intravenous dosing, which is why that has become generally standard of care. There are other ways to prevent peripheral neuropathy, for example, vitamins, alpha-lipoic acid, sort of over-the-counter preventions. Some medications like gabapentin may be used to treat them. Also, medications like pregabalin or Lyrica, duloxetine, or Celexa. Sometimes opioids are necessary, but I like to go to those as my last place. And I really try to go to more nerve-based therapies for this peripheral neuropathy. Some of my patients have also used acupuncture or physical therapy. We talked about acyclovir and valacyclovir to prevent the potential for developing shingles, and blood thinners, which is really more when you have to combine these with IMiDs. So what about the immunomodulatory agents that are available for 1 to 3 prior lines of therapy? As I already mentioned, Revlimid is one of the ones you've probably heard of already. This is a once daily pill for 3 weeks on, 1 week off, and can be combined with dexamethasone or a host of other therapies that are available in the second line setting. Pomalyst is also a drug specifically for relapsed myeloma, sort of the newer cousin to Revlimid. It's also a once daily pill and can be combined with dexamethasone and other agents in the relapsed refractory setting. So Pomalyst has had several studies to prove that it is actually better in the relapse setting. So Pomalyst versus high-dose dex was the original MM003 trial. That sort of put Pomalyst on the maps, Pom-dex versus dex, and did show an improvement in progression-free survival. And more recently, we have the Optimism study, a phase 3 trial that compared Pomalyst, Velcade, and dexamethasone, also known as PVD, to VD, or Velcade and dexamethasone, in patients with 1 to 3 prior lines of therapy. And that also showed that adding in Pomalyst yielded a nice improvement in progression-free survival of 11 months versus 7 months. And for that reason, we do have Pomalyst approved in the setting of relapsed refractory myeloma. What about the side effects for the various IMiDs? Really looking here at Revlimid and Pomalyst, because these are the two that are most used in this setting. So Revlimid, I'm sure many of you know, can cause or make you likely to have a blood clot. We particularly think this is true in the setting of high-dose dexamethasone. Of course, Revlimid can cause low blood counts, rash, diarrhea, and fatigue. I'd say fatigue is one of the things that I most commonly hear about, especially in the second line or even in the maintenance setting. And there is a small but real chance of second new cancers if you've gotten this after previously having gotten melphalan. So it's a small percentage increase, but it's a real one. And that's why we are very careful about asking patients to keep on top of things like mammogram, colonoscopy, and of course, dermatology and having good derm exams, because you may have the propensity to develop, for example, a squamous cell carcinoma or something on the skin that people commonly develop, especially as they get older. Now, for Pomalyst, similarly, it can cause fatigue and weakness. And one of the things that you may hear a lot about is lower white blood counts, which is definitely a side effect, as well as some GI effects. There have been reports of shortness of breath and upper respiratory tract infection as well, possibly related to maybe the lower blood counts, also blood clots with this, so you have to be on a blood thinner. Speaking of which, managing the side effects of the IMiDs is something that you probably have heard of, and we have gotten good at it over the years. The blood thinners are key. Like I said before, the likelihood of having a clot is probably worse if you have a lot of disease and if you're getting higher dose dexamethasone in combination with either Revlimid or Pomalyst. Sometimes people like to use tonic water, increase fluid intake. This really does help with overall hydration status, decreasing the fatigue, and maybe actually decrease for cramps. The GI toxicity can be sort of a pendulum between constipation and diarrhea. We do use Imodium, and we also use cholestyramine to help with that, and sleep hygiene. And we've thought about when we can take the pill and coordinate it with your own circadian. For example, a lot of my patients like to take Revlimid at night because they have this fatigue after it, and it goes well to have it at night versus having fatigue during the day. Patients also might notice that certain foods, they get irritated a little bit more with either Revlimid or Pomalyst and sort of change their diet accordingly. It's really important to listen to your body, because it's hard to know with all these things going on what does work and what doesn't work, and it's hard to see with case reports, but it's ultimately you know your body the best. And sometimes my patients even do a food diary to help them understand what they can tolerate and in what combination. So we do have monoclonal antibodies, as I said, and they have certainly revolutionized myeloma therapy. There are 3 of them that are available on the market. The first targets SLAM-F7. That's called elotuzumab. That protein is on the surface of plasma cells, which is the malignant cell in myeloma. The trade name for that is Implicity, and you can get that weekly for the first 8 weeks, and then every 2 weeks. If you get it in combination with pomalidomide, then it goes to every 4 weeks. And this is for patients with relapsed refractory multiple myeloma, either with Revlimid or in later lines with Pomalyst and dexamethasone. Darzalex, or daratumumab, is an anti-CD38 antibody that used to be IV, but now is available sub-Q. It's weekly for 8 weeks, then every other week for 16 weeks, and then monthly thereafter, which actually can be nice and convenient, just one subcutaneous shot per month. That's approved both for relapse refractory and frontline therapy, but in the relapse setting, it can be a single agent or as a triplet with Velcade, Kyprolis, or Pomalyst plus dexamethasone. And now you can see that we've started to move this daratumumab up front, or Darzalex up front. Some people may have already had Darzalex before they go to relapse refractory stage. So that's an evolving area of research. And then there's Sarclisa, or isatuximab, also a very effective CD38 antibody. It's given IV right now. No sub-Q formulation is yet available. Usually it's given once a week for the first 4 weeks, then every 2 weeks. This is also approved for relapse and refractory myeloma in combination with Pomalyst or Kyprolis and dexamethasone based on randomized phase 3 data. So here's a host of trials, a laundry list, and I don't want to make this too confusing, but to sort of think about what it is and how these drugs got approved, it's reassuring to know that these things have been done in very robust fashion, so that if you're getting prescribed these combinations, it's because we know they work. And the way we know they work is through phase 3 trials and other trials that have had comparison data to real world. So the first trial, Pollux, randomized patients to get Dara, Rev, Dex, DRD versus RD, showed a very nice improvement in progression-free survival. Similarly, the Castor trial, Dara, Velcade, Dex versus Velcade, Dex, or DVD versus VD, again, nice improvement in progression-free survival. Candor, a remarkable trial, phase 3, Darzalex, Kyprolis, Dex, also known as DKD versus KD, showed a very nice improvement of PFS with a PFS there of 28 months. Very, very nice. And then there's Equilius that looked at Dara-Pom Dex, which does have a nice improvement of what you would think as historical trial. But of course, we know that Dara-Pom Dex has also been studied in the Apollo trial as well. Implicity, which is the anti-SLAM-F7 monoclonal antibody, has been studied in Eloquent 2 and 3, either Implicity RD or ERD versus RD. And then in Eloquent 3, Implicity PD, EPD versus PD, both of which showed an improvement in progression-free survival. Finally, Sarclisa or isatuximab, that's the other CD38 antibody, has been studied in 2 settings. For the ICARIA study, this was with patients who had received 2 prior lines of therapy, so a little bit sicker than 1 to 3 priors. And that looked at Sarclisa Pomdex versus Pomdex. Very nice improvement in progression-free survival there as well. And most recently, the IKEMA trial for patients with 1 to 3 lines of therapy. So like we were just talking about in this patient setting, Sarclisa carfilzomib dex versus carfilzomib dex, a very nice improvement in progression-free survival. And as of yet, we don't even know what the final progression-free survival data is because people are still doing well on that trial. So we look forward to that data. This is not meant to necessarily confuse you, but to give you an understanding of why we may choose a certain drug in a certain setting or a certain combination, because we have data to support that in general, 3 drugs are better than 2. So what about the side effects and management? I have to say the monoclonal antibodies actually are very well tolerated after the first 1 or 2 doses. And even in the first dose, now that we have subcutaneous dosing for at least one of them, so implicity may cause low blood counts or infusion reaction initially. Remember, these are antibodies, they're biological treatments, so your body sees them as sort of a foreign thing. And so it can have like flu-like symptoms afterwards. Darzalex and Sarclisa, which are CD38 antibodies, if they're infused, can have infusion reactions, also have fatigue and a little bit hint of increased upper respiratory tract infections, as well as low blood counts, in particular when combined with treatments like Revlimid or Pomalyst. I will point out that the Darzalex sub-Q has fewer infusion reactions and it's more injection site reactions because it's given subcutaneously, not intravenously. Now, how do we manage these? Pretty easily with pre-medications, for example, Tylenol, Benadryl. Sometimes we use a drug called Singulair. Sometimes people use Zyrtec. And then also giving steroids not only on the day of, but sometimes on the days following these medications. Now, there are some new modes of action, and I talked about this briefly, Expovio or selinexor, which prevents important proteins from exiting the nucleus, especially in myeloma cells. That's a once-weekly pill, and it can be given twice weekly as it was originally approved, but does in combination come in once weekly pill and is for relapsed refractory myeloma. Now, if it's 1 to 3 prior lines, you can combine it with Velcade in a weekly form because of the Boston trial, which is seen here, which is a phase 3 trial that showed that selinexor Velcade dex, or SVD versus VD, gave a very nice improvement in progression-free survival, which has been really important in getting this drug approved in the relapsed refractory setting. And the weekly dosing makes it much easier for a patient. And in fact, in this trial, the Velcade was also weekly dosing and not twice weekly. So that's much more patient-friendly approach for patients with relapsed refractory myeloma. Now, there are supportive care strategies for Expovio because it is known to cause a significant amount of nausea, fatigue, low appetite, and low blood count. So most importantly, to know to anticipate these. And what we often do is give very, very strict and very prescribed anti-nausea medications. So you may get Zofran every day, several times a day for that first week. And we may start a drug called Zyprexa, which you can get at night in a low dose, which will help to improve your appetite and decrease your nausea. There can be low sodium levels. And for the first 1 to 2 weeks, we may actually have you come in for IV fluids weekly just to do a check. But also, for example, if you were coming in for Velcade, you'd be coming in anyway, so it's a good time to check that. We may also consider giving oral salt tabs, which are kind of not pleasant to take, but better than getting IV therapy. And then fatigue. We talk about things like changing your life schedule around so you can be hydrated, stay active, sleep when you're supposed to sleep. Sometimes people have used drugs like Ritalin to help with that. Low blood counts. Now, this is something that we are managing. Now, remember, when people get these drugs, they've already had previous drugs. So they're a little bit prone to low blood counts. And so if there are any signs of bleeding or infection, we have to jump on that right away. We do actually like to use growth factor, not only Neupogen, which you may have used to increase your white blood cell count, but also something called Nplate or Eltrombopag, and these things can actually, or Promag, these can actually increase your platelet count. And I've actually used those with people who are getting Expovio as well. So I want to move on now to options for patients who are triple class refractory. Triple-class refractory patients are those who've been treated with and did not respond satisfactorily or progressed to the three main categories of drugs, also known as proteasome inhibitors, immunomodulatory agents, and anti-CD38 monoclonal antibodies. Now, we have a bunch of drugs that are approved in this setting, but in a sort of different format. We talked about Xpovio. In that case, it's a twice-weekly pill. We talked about Blenrep, which is belantamab mafodotin, which is an intravenous drug once every 3 weeks. And this is targeting BCMA with a targeted deployment of this antibody drug conjugate poison, as we call it, or it's more antibody drug conjugate anti-myeloma treatment, which is this MMAF, which is sort of this deployed weapon against myeloma cells specific at the BCMA targeting aspect. And then we have CAR T cells, which are known as Abecma, also known as idacaptogene viclucel or ide-cel, and Carvykti, also known as cilta-cel. These are both BCMA-directed CAR T cell therapies that are approved for relapsed and refractory myeloma for patients who've gotten 4 prior lines of therapy. And I want to be really clear about that because the antibody drug conjugate Blenrep is approved for patients who've gotten 4 therapies, which may include a combination of this anti-CD38 PI, proteasome inhibitor, and IMiD, and those might be done in earlier than 4 lines. But the FDA was very clear about 4 lines of therapy, 4 separate lines for the CAR T cells. So it's something that you might have to sort of work out with your oncologist to know if you're eligible to get this. Now, just to go back to the belantamab mafodotin antibody drug conjugate mechanism of action, this is again a specific drug, a drug that targets BCMA, but is conjugated to an MMAF. And that MMAF is taken in when the antibody binds, and it's taken into the cell and then released from that antibody in a lysosome. And that's a little particle inside the cell. And now that antibody drug conjugate part of it, the MMAF toxin, can specifically kill the myeloma cell after having gone in there because of the specific BCMA binding. So it's a really nice way to have targeted deployed toxicity to myeloma cells and get that done. It was the first drug that targeted BCMA and is available off the shelf. This is the first antibody drug conjugate approved in myeloma, and it's been approved at a dose of 2.5 milligrams per kilogram based on the DREAM2 study, where patients had a lot of prior therapies. I believe they were 8 prior lines of therapy, and their overall response rate in that group was 31%, with a median progression-free survival of 2.9 months. But I will say the duration of response, so people who did respond, it lasted about 11 months, and the overall survival at the reporting had not been reached. I think one of the most important things to remember about Blenrep is that it does cause a specific side effect of keratopathy, or what we call ocular or eye side effects. And that means you have to be connected to an eye care professional. So there is a REMS, or a risk mitigation system, that is mandated by the FDA. So you have to see an eye care professional every 3 weeks before you get this particular infusion to make sure your cornea is still intact. And if it's not, there may be some dose delays. Even though you might not be symptomatic, even though you might not have blurry vision, we would still delay you to protect this from developing. There's also side effects that are having to do with blood counts. For example, low platelets, that's one of the other side effects. And again, we can use some supportive care to manage that. We're very excited to have 2 CAR T cell therapies approved. This is based on this remarkable data for both Abecma and Carvykti, where Abecma had a 73% response rate. That's something we don't see responses in the 70s or 80s for relapsed refractory myeloma. These people had a median prior lines of therapy of 6. So that's way more than we'd seen in these other studies that we talked about. 73% of patients responded to Abecma, and 97% of patients responded to Carvykti, which is really unprecedented. Really nice data there and very nice responses. We don't know the duration of response yet for the Carvykti, so we're looking forward to seeing how that happens and how that data unfolds. This is a process that you have to be connected with your provider. This does require apheresis. This is a procedure similar to what you may have done for stem cell collection, but there is no high-dose Neupogen, and it's usually just 1 day. Thereafter, there's a period of waiting, about 5 weeks or so, and at that time you may get some other therapies to hold your myeloma over, and then you'll be coming back to the specialized center to get 3 days of lymphodepleting chemotherapy, fludarabine, and cyclophosphamide. That's really to make space for the main show, which is the infusion of the cells. And usually people stay in the hospital. Well, it's going to depend, but some people stay in the hospital 1 week or 2 weeks, but really close to the hospital for that first 28 days. So you kind of have to think about it in the same schema of transplant, but it's a completely different mechanism of action. Now, the reason we want you to stay close by is because there are some known toxicities cytokine release syndrome, also known as CRS, which is like a flu-like syndrome, can affect any part of the body, neurotoxicity, which causes confusion and can come on sometimes after CRS. And then there can be low blood counts and risk for infection, as is true with all myeloma therapies. So if you think about transplant versus CAR T, we like to compare them, but they're really different. CAR T cell therapy does have a cell collection, but it's T cells, and those cells are engineered, whereas the stem cells are not engineered. Those are just stored. And the chemotherapy that you get for CAR T cell therapy is much less versus the melphalan, which is a high-dose chemotherapy, and that's what's really doing the work. The CAR T is given after multiple relapses. Stem cell is usually in the first line, as I talked about in the beginning, and the side effects are totally different. CRS, confusion, that's more with CAR T, and nausea, vomiting, diarrhea, traditional chemotherapy side effects are with the autologous transplant and the high-dose melphalan. Second transplant is an option if you've had stem cells that are stored. We have some studies, this one is a randomized trial looking at getting a second transplant versus just conventional chemotherapy, and there was an improvement for patients who got a second transplant. Traditionally, we think that patients that have had more than 2 or 3 years from their first transplant, those people would be considered for a second transplant in the future. That's why we do typically collect cells for more than one transplant. So in summary, relapsed and refractory multiple myeloma is treatable. Patients typically receive multiple lines of therapy and combination therapy, and it's continued for an extended period of time. So many new drugs approved and available in the last 9 years. There's a whole laundry list here, and we're excited to have more. And with the introduction of each new drug, there's a potential for additional combinations and more effective combinations. In addition, there are many promising new drugs, new combinations, new therapies, and modalities in clinical development. And we really are so grateful to all the patients who have participated in clinical trials and made this a reality as a standard of care. With that, I'd like to say thank you and looking forward to updates on the horizon from my colleague, Dr. Usmani.
Hello, everyone. My name is Saad Usmani. I'm the Chief of Myeloma Service at the Memorial Sloan Kettering Cancer Center in New York. And I'm going to be taking over from where my colleague, Dr. Nina Shah, left off. She talked about the options that are available to patients. And now I'm going to start covering options that are on the horizon and kind of focus in a bit on what's happening on the precision medicine end, as well as some of the emerging immunotherapeutic options that are coming down the pike. So, as we think about the options that are coming down the pike that are relevant to precision medicine, there's several that are in early phase development. The Multiple Myeloma Research Foundation, has a Multiple Myeloma Research Consortium where we're running a trial called MyDrug, where we're actually exploring disease pathway biomarker-driven, mechanism of action-driven options for our patients in the early relapse setting, and seeing if there is a therapeutic signal, in subsets of myeloma. I think, the overarching theme is myeloma is not one disease. So we have to start thinking about developing therapeutic options for patients based on the disease biology. So here, the best example here is venetoclax, which is what we call a BCL2 inhibitor. It's an oral drug. It comes in the pill form, and it's in phase 3 trials. It's found to be fairly active in patients who have a specific chromosome abnormality called translocation 11;14, and we're going to talk a bit more about it in the subsequent slides. So, the point I was making, myeloma is not just one disease. We have several different subtypes of myeloma based on the cytogenetic abnormalities that those cancer cells carry. And the future is, we are going to move away from this one-size-fits-all approach and try to move towards a more disease biology-specific approach. So how do we do that? How do we customize those kind of treatments? That's what precision medicine is all about. It's very likely that in the next 5 to 10 years, we're going to have, at least 5 or 6 different approaches to approaching myeloma treatment based on some of these baseline features that the myeloma cells carry when the patients are diagnosed. So I'll start with one example. This is, from the MMRF COMPASS study. So we have 2 patients Similar in age, one is 72, the other is 71. Their ISS staging at the time of presentation is similar. Their baseline cytogenetics are high risk and similar. But one patient, and both of them get the same kind of treatment, baseline treatment with VRD. But for one patient, the one on the left, the time to progression is 1 month, and for the other patient, it's more than 18 months. So what is the difference between these two? It has to do with disease biology. So if we, when we looked at this tumor suppressor gene called P53, that was mutated in the patient in the first column, and that was what was driving the disease process. Whereas on the right side, the patient had the wild type. So that patient actually did better in terms of their outcomes compared to the one in the first column. And when we look at multiple myeloma, it's not a one pathway disease. So precision medicine efforts have recognized many different alterations, genetic alterations in myeloma cells. And so these alterations may be the Achilles heel of these myeloma cells. That's why using the right type of therapeutic approach would be important. Not all of these genetic abnormalities are actionable at the current time, but that's the aspirational goal we have. That's why we're doing clinical trials like the MyDrug study. Going back to venetoclax, I'd mentioned that this is the prime example that we have right now. Venetoclax is a BCL2 inhibitor. It appears to be quite active specifically in patients who have translocation 11-14. And these patients tend to have an overexpression of a gene called BCL2. And in studies where we have combined another inhibitor called MEK, there's another gene called MEK, and if you inhibit that along with BCL2, there appears to be very good activity. You can see almost 100% of the patients, in that particular study actually showing a response, when patients have those 11-14 abnormalities. So again, going from a totally, genetic karyotypic abnormality agnostic kind of a one-size-fits-all approach to approach that would be very relevant therapeutically to a subset of patients. So this is just an example of what precision medicine can do. So I've mentioned the MyDrug study. This is the design. So the objective of this trial that my colleague, Dr. Shaji Kumar, has envisioned and leading within the MMRC is to identify patients who are functional high risk. So these patients have an early relapse, within 18 months or so. We profile them. If we find a specific abnormality, these patients get that abnormality-specific therapeutic intervention for 2 cycles before they have standard of care treatments added on to that backbone. And so the idea is to see if there's a signal, therapeutic signal with that kind of an approach. And for patients who do not have an actionable alteration, there are other therapeutic interventions, such as IPD along with selinexor or belantamab or daratumumab that can be employed. For translocation 11-14 patients, venetoclax is being added to IPD, and there's a control arm of IPD or ixazomib, pomalidomide, dexamethasone. So this is a very innovative study, and we hope that this will continue to guide our efforts towards precision medicine in the coming years. So this is a nice case study, an example of a patient, who received, VRD and KRD as part of induction, got a transplant, and then lenalidomide maintenance. They had a CR as best response, but they progress within 2 years of having received a transplant. They get a second-line treatment with elotuzumab, pomalidomide dexamethasone, they have a minimal response and progress within 4 months. So now they're at their third line treatment, and they get, cycle one of this therapy, on the MyDrug trial. And when the genomic profiling was done, this patient did have MYC amplification, which is a recognized abnormality in more aggressive myelomas in subsequent lines of treatment. The patient also had NRAS mutation in 56% of the allelic fraction. And they go on this study, and on the cohort 1, and they have a wonderful response in terms of M spike as well as serum free light chains. And we're looking at months of treatment. You can see that this patient not just responded, but has had an ongoing response that's going up to 13 months and likely beyond 13 months. So, if I were to summarize this part, I would say efforts are underway to better understand the nature of disease. We are doing these precision medicine efforts where we are genomically profiling patients and picking appropriate patients. And this sequencing data will help us identify the subtypes and also, help us in generating collective wisdom for the field. I would advise patients to ask your physicians if this kind of an approach is right. It's always a good idea to seek an opinion from a myeloma center of excellence, and then see if there are any specific genomic subtypes that may actually influence treatment decision making. So precision medicine, it's not ready for prime time, but we are heading that way. And the hope is that it will provide the right treatments at the right time for each myeloma patients. So with that in mind, let me talk about some other immunotherapy options on the horizon. So in terms of immunomodulatory drugs, iberdomide is CELMoD. It's an oral drug. It's comes from a derivative of thalidomide and its analogs. And it's quite active, and it's moving into phase 3 studies. Then we have several immunomodulatory drugs that actually have antibody-based as well as oral therapy-based options in the immunomodulatory category. Then we have several naked antibodies. So the idea of naked antibodies is to identify specific surface markers on the myeloma cell and help the immune system go after those cells. So several efforts in that realm. And then we have novel antibody drug conjugates. So here, a naked antibody has a toxic or chemotherapy payload attached to it. And when the antibody recognizes the cancer cell and internalizes that antibody, that toxic payload is released and kills the cancer cell. And then several bispecific antibodies, I think this is probably the most exciting area that we have. So bispecific antibodies can help recognize one part of the antibody recognizes the cancer cell. The other part of the antibody can recognize an immune cell like T cell and NK cell, and they can help make the T cell kill the cancer cell. So we've seen excellent results in clinical trials with some of these approaches. Teclistamab targets BCMA. It's the farthest along in its clinical development, but there are several others targeting BCMA and GPRC5D and FCRH5 that are in development as well. CAR T cell therapies continue to be an active area of research. We now have several BCMA targeting CAR Ts that are farther ahead in terms of their clinical development. We already know from Nina's talk or Dr. Shah's talk that, two of the BCMA-directed CAR Ts are now FDA approved, but there are several that are trying to improve the deliverability of the therapy in a faster fashion, especially some allogeneic BCMA-directed CAR Ts that are in development, which will be off the shelf, so ready to go for our patients. And then novel checkpoint inhibitors. So checkpoint inhibition is a way of trying to rev up the immune system, which is tired under the barrage of the myeloma cells kind of growing and continuing to affect the immune system function. So the checkpoint inhibitors are geared towards helping reverse some of that, immunoparesis and immune energy. Let me just talk about some of these immunotherapeutic approaches. We've talked about the monoclonal antibodies. We've talked a bit about, IMiDs and cell mods, which help, overcome that immune suppression. CAR T cells and T cell engaging antibodies are trying to redirect the T cells to help fight the myeloma cells. But the next area, which is also very exciting, is the vaccine. So this is a nascent or an active area, but farther behind in terms of seeing coming to fruition for our patients. There are several clinical trials, but the data is still early. But the concept is activating myeloma-specific immunity, in patients. So CAR T cell therapy. Right now we have BCMA-directed therapies. The process here is, we take the T cells from the patient, and those T cells are then engineered, or in a way where we introduce chimeric antigen receptors into those T cells. Those T cells then get activated when they encounter that specific target. In this case, it's BCMA. That whole process of taking the T cells from the patient, introducing that viral vector that carries that CAR constructs into the T cells through a process called transfection. That whole process takes about 3 to 4 weeks, and then the product is sent back to the transplant cellular therapy center. Patients get a low dose of chemotherapy to dial down the immune system, and then the CAR T cells are infused. And this is a very promising approach. What we've learned from CAR T cell therapy so far is all patients who have been heavily pretreated with at least 6 prior lines of treatment and are considered triple-class refractory. The activity appears to be very good. The side effect profile is somewhat similar. Cytokine release syndrome, sometimes neurologic side effects, confusion and low blood counts, all of these tend to be reversible for the most part. And most patients respond well to treatment. And the duration of response, can vary from 9 to 21 months. But still quite unprecedented compared to some of the other options we have in this space. So of the CAR Ts that are on the horizon, CT053, the Poseida construct, PBCMA101, and then the allogenic, construct ALLO-715, which will be an off-the-shelf option, are the ones that we're going to be paying close attention to. Bispecific antibodies, as I explained, one part of the antibody can recognize the cancer cell, the other part can identify the patient's T cell and bring them together to do the killing of the cancer cell. And this is off the shelf. So, I can, if I see, once this therapy gets approved, if I'm seeing a patient in the clinic today, I can prescribe this treatment and they can receive it fairly quickly, within the next few days. So, that's kind of the advantage, and the activity we're seeing with bispecifics is getting very close to what we're seeing with some of the CAR T cell therapies. I have to say that, that there are going to be, these bispecific antibodies are going to be, very effective options for our patients in the clinic. The key issue or difference here is, unlike the CAR Ts, where you get the CAR T cell therapy and the patients are not on any maintenance treatment, if they respond, when you get a bispecific treatment, you have to, patients have to continue to take it. However, the response rates are good. Just like CAR Ts, patients do get cytokine release syndrome, and some can get neurotoxicity. But overall, the grade of the CRS is only grade 1 and 2 for the most part. And there are patients who don't develop CRS with some of these bispecific antibodies. So, I think in the future, as we're thinking about, how to pick, one option over the other, we are going to be thinking on how, about how quickly patients will need treatment to pick between CAR-Ts and bispecifics, and also see, if patients can actually withstand higher grades of CRS. So, some of this will be clinical acumen and needs of the patients that we're going to be thinking about. We talked about, a bit about iberdomide. So this is an oral CELMoD, which is related to the immunomodulatory drugs, and in early studies has shown very good activity, about 1 in 4 patients responding, even those who have received prior BCMA-directed treatments, so including CAR-Ts and antibody drug conjugates or bispecific antibodies. So appears to be very active, and it's being now studied in earlier lines of treatment. And then, this new class of therapies called immunocytokines, where an antibody is attached to, interferon. When it's delivered to the cancer cells, it's shown to be very effective in generating cell kills. So there's some good early data, even in patients who've had prior anti-CD38 antibody treatments, such as daratumumab or isatuximab, or even BCMA-directed treatments. A little over a third of the patients appear to be responding to this treatment. So if I were to summarize this section, I'd say CAR-Ts are extremely promising. Durable remissions. We haven't seen any increase in toxicities when we're using in early lines of treatment, and it's one and done. So you do the CAR-Ts, yes, it's a bit more labor intensive early on, but then when patients recover from those side effects, they're not on any therapies. Bispecifics are off the shelf, so you can treat, and they appear to be very effective. So depending on how quickly patients need it, we can use this, and there are several targets: BCMA, GPRC5D, FCRH5, that are being used, for these bispecific T cell redirection approaches. And then next generation IMiDs, which are called CELMoDs, such as iberdomide and mezigdomide, they're going to be very important part of combination treatments, and they might even replace Revlimid and Pomalyst in the future in some settings. And we are doing clinical trials right now to make those determinations. With that being said, I'd like to thank all of you for your patience and for listening to me.